All right, good afternoon and welcome to our virtual town hall devoted to COVID-19 vaccines. I'm Stephen Ganji, Professor of Epidemiology, Executive Vice Provost for Academic Affairs, and one of the co-chairs of the 2020 COVID Task Force Steering Committee. I'm delighted to be moderating this session with four of our distinguished Johns Hopkins faculty. Dr. Lisa Cooper is a Bloomberg Distinguished Professor of Health Equity, the James Fries Professor of Medicine, and Director of the Johns Hopkins Center for Health Equity and the Urban Health Institute. Dr. Nancy Cass is the Phoebe R. Berman Professor of Bioethics and Public Health and Vice Provost for Graduate and Professional Education. Dr. Gabe Kellen is Professor and Chair of the Department of Emergency Medicine, Director of the Johns Hopkins Office of Critical Event Preparedness and Response, and Director of the Center for the Study of Preparedness and Catastrophic Event Response. And lastly, Jonathan Links, Professor of Environmental Health Sciences, Vice Provost, and Chief Risk Officer, as well as a member of our 2020 COVID Task Force. Many of you have seen the recent news, such as in the Johns Hopkins Hub yesterday, that Johns Hopkins Medicine has received the initial doses of the recently authorized Pfizer COVID-19 vaccine this past Monday, and that vaccinations would begin this week for high-risk healthcare personnel. Further, as I'm sure you all know, today the FDA Advisory Committee is meeting to discuss the approval of the second COVID vaccine by Moderna. We organized today's session in response to many questions that we have received in various settings from our affiliates around the vaccine. The goal of today's town hall is to hear from our faculty what is currently known about the efficacy and safety of the new vaccines, what we generally know about how the vaccines will be distributed, and how the JHU community can come together to build trust and overcome vaccine skepticism. I'll preview that this is not a town hall presenting an operational plan for vaccine distribution at Johns Hopkins. While we'll share what we know in broad terms, there are many uncertainties remaining about vaccine distribution and how this will impact you as faculty, staff, postdocs, and students. Healthcare personnel and others working at Johns Hopkins Medicine have received information previously about vaccine distribution efforts there. In our session, which will be recorded and made available on our website, you do have an opportunity to submit questions live, and we appreciate those that we've received beforehand. There should be a box under this screen that allows you to submit questions that we'll answer to the extent possible. So I'm going to first turn to Dr. Kellen to start talking a bit about what we know about the vaccines that have been approved, including giving a brief summary of the vaccines themselves, key clinical trial results, and the safety protocol. So Dr. Kellen.
Thank you. I'm going to go ahead and start sharing my slides, if that's okay. And pleased to be here. Very happy to be part of this terrific panel and to have an opportunity to chat with you. I'm going to go fairly quickly so that there's time so that there really is time for questions. So there's 4 different types of and various variations on the theme on the types of vaccines that are being developed. Today, we're mostly going to talk about the mRNA genetic vaccine, but others are coming on down the pike, like the viral vectors, for example, AstraZeneca that you've heard of, piggybacks viral code onto a virus, in this case, an adenovirus, injects it in you and does its thing. I'll show you in a minute. Proteins that make its way into the body that are synthesized to look like bits and pieces of the virus, and the body sees it as foreign and develops antibody. And then what you're particularly more used to is inactivated or dead virus, like mumps, measles, rubella, that gets injected into you, and the body doesn't know whether it's alive or dead. It doesn't really matter. It develops antibodies to it. Now we're going to talk about mRNA because there are a lot of questions. It feels like it's fairly new, but it's actually been in about a decade in development. There just hasn't been a good pandemic thus far to test it. But if you believe in the beauty of science, this is about as elegant and beautiful and almost poetic and just a brilliant methodology that people had come up with. So the Chinese put the code out on the internet for the virus, I think in late December. In January, a number of companies took a very specific part of the code and synthesized a messenger RNA. They put it in a liquid envelope, and that, sorry, not liquid, lipid envelope, that's fat, which allows it to get into the cell. And then the messenger RNA tells the cell to make a specific type of protein. In this case, it's the spike protein that is on top of the coronavirus. It gets its name from this spike protein concept. These little spike proteins then get released from the cell. The immune system sees it and gobbles them up and says, I'm going to be ready for the next time you actually get an infection or the virus invades your body, and I'm all set. This is about as nice as science actually gets. So here are the 3 vaccines in terms of their status. The Pfizer is in fact here, an EUA has been issued. We expect an EUA for Moderna tomorrow. AstraZeneca is in a little bit of a mess. You've probably read in the news, and in the question period we can get into that. They're probably weeks and months away, if that, from getting any kind of authorization. All of these 3 require 2 doses. There's some serious handling issues. The Pfizer has to be stored at -70. In English, that's like 94 degrees Fahrenheit. So that's pretty cold stuff. Sorry. In terms of what we're getting, there's about 44 million doses between Pfizer and Moderna. Pfizer has about 100 million, and the US is trying to purchase some more. Moderna, the US had purchased 100 million, and has now since authorized yet another 100 million for the US. So about 300 million doses coming down the pike, which is good only for about 150 million people. Now, the trials, both Pfizer and Moderna, did not include pregnant women, although they're allowed to get the vaccine, by the way, or children. It did include some immunocompromised, and the Pfizer one included people with previous infection. Most important was that these trials have to have age groups in risk areas, like over 65, at least a quarter of the people, people in underrepresented ethnic or racial groups, and a fair number of people with comorbidities, including obesity. So here's the result. So most of you know Pfizer is 95% effective, but what was particularly gratifying is that it's 95% effective in those over age 55 as well. And it largely prevents severe disease at a ratio of 10 to 1. So that's a very, very significant development. And it's maintaining these results for those with and without comorbidities. It doesn't matter which of these comorbidities you have, it's a very, very high rate of effectiveness. Efficacy is actually the real world. We'll talk about that in a minute. There's a bit of a surprise for Pfizer. This did not hold for Moderna. Pfizer started showing immunity at 10 days. So the second dose is still advised, more than advised, it's required so that you can get more long-lasting immunity and a stronger sense of immunity. But you could see in this slide that by 10 days, some serious immunity is available after the first dose. Moderna does not believe that their mRNA vaccine showed the exact same thing. This is an important slide because there are probably more side effects than with other vaccines. Now, most of them are what you might expect: fatigue, fever, chills, headache, myalgias. But as you can see, some of them, it's the gold, can be severe. Can be severe in some of the cases. The dose that Moderna is coming out with is the middle dose, so fortunately Not much of that is in the severe category, but it'll be enough that some healthcare workers, when they get it, will not feel like coming to work. Side effects, serious non-fatal side effects are about the same in both the vaccinated and placebo group, and the kind of side effects are like really not related to vaccination: appendicitis, heart attacks, strokes. In the placebo group, pneumonia, atrial fibrillation, syncope. I'll talk a little bit further about Bell's palsy because that's sort of starting to pop up just a little bit. For those of you who don't know, Bell's palsy is a condition of the 7th cranial peripheral nerve. Sometimes it's associated with things like Lyme disease and upper respiratory infections a few weeks before this happens, but it takes out the 7th nerve that controls facial muscles, and so people have this facial droop, they can't close their eyes and so forth. In other terms of safety, you've certainly heard that some people have very immediate effects, not much difference in either the Pfizer or the Moderna trials in terms of immediate effects. However, you are aware probably of 2 cases of anaphylaxis in people who are highly allergic in the UK. In Alaska, yesterday was reported a person who wasn't particularly allergic to anything, and then a second patient was reported today, but they only had symptoms for about an hour, went to the emergency department, left, and have been fine since. So here's the comparison between Pfizer and Moderna, high level of efficacy all the way through, with one exception. Moderna was slightly less for ages 65 and over. So that is, is that a concern? Let me say that originally the FDA was going to approve any vaccine that was over 50% efficacy. Public health officials would have been happy with 60 to 70%. Anthony Fauci said that 75% would be terrific. So anything in this range of 90, 95%, 85% is like everybody on the team hitting a grand slam. It's just numbers that were truly not anticipated. Both prevent severe disease, and both have fairly good lasting immunity. Serious side effects not apparent. In the trials, there wasn't any anaphylaxis, and hypersensitivity was, at least by numbers, a tad bigger in the Pfizer and Moderna. Deaths were either the same or slightly less, and the deaths were not seemingly related to vaccination. A couple of caveats though: efficacy is not the same as real world results, so we'll see what the actual effectiveness is. While the data were reviewed by independent committees, it has not been peer reviewed in the sense that we understand it. It's not known that if you're vaccinated and immune, whether you can actually be infected and harbor the virus and spread it to other people. I'll talk a little bit later about long-term side effects. It's of some concern that the standard side effects of muscle aches and fevers and so forth are very similar to the initial symptoms of COVID. So you may not be able to distinguish, other than that if it's related to the vaccine, that should be gone about 24 and definitely by about 48 hours. To let you know that our approach at Hopkins, we put a pretty serious committee together. Nancy Cass is on it, who will be speaking a little bit later, but we had just about everybody: patient safety people and risk management people and pediatricians and nurses, and John Links himself was on this, and he'll be commenting later too. I'm not going to show all of our deliberations. I'm going to just very briefly talk about 3 of them. Can we trust the process? We started this when the White House looked like they were interfering strongly in the approval process. I'm not going to go through all the reasons that we do, but the truth is we do trust the process for both Pfizer and Moderna. Both of them, the safety monitoring boards are truly independent from either the government, CDC, or the FDA, or Pfizer itself. We broached the issue as to whether vaccination, particularly in the healthcare setting, should be mandatory, because we made the flu vaccine mandatory, but no, an emergency use authorization, we felt, doesn't imply full licensure. It's for a restricted approved use. You don't actually even need consent, mind you, but we are, when we're administering it, we're giving it by consent. So this is sort of the where we stand in terms of how much is available. 300 million likely in the US of just these two. In the short run, about 44 million, 45 million. A small amount of that for Pfizer, maybe a little more for Moderna as early as Monday. And drilling right down, we got, including Sibley, which is in DC. For the health system, last week we got a little over 1,000, and today we received between Sibley and us another 4,000. And we anticipate getting about 3,000 doses a week of just the Pfizer and or perhaps the Moderna. So we developed probably maybe too elaborate, but a very elaborate priority allocation based on the CDC wish that healthcare workers be allocated first, as long as assisted living and nursing homes. So we took a slightly different tack. We looked at, well, who was so essential that were hard to replace that we had to maintain the workforce. And so it's obviously mostly people who are in clinical care, but it also, there were also a lot of people who support the clinical care that without them, and I'll show you that in a minute, just we couldn't do without. Obviously the folks taking care of COVID patients were highly favored, but you can see here that we have all the way up to 6 phases. And most of you, if you're not in a healthcare setting, are going to be here in phase 6. This is just to show you how complicated an allocation actually gets, and all the different types of people we have to consider as who has an essential role. And these are just the other groups. I'm not going to show you the phase 2, 3, 4, and so forth. We have a very, very simple way to register for this. We have like up to 60,000 people to vaccinate in the healthcare setting alone, just in our health system. If you have MyChart, which many of you probably do for other reasons, in 10 seconds you can register if you're interested in the vaccine, and then we randomize the whatever amount that we have, because obviously we don't have enough for 60,000 people. And you get a ticket and you have a chance to schedule an appointment, and off you go. And as of yesterday, we did about 150 people. Probably by the end of today, we'll have close to 200. This is kind of like what our dashboard looks like. And just in the 1A, B, and C group, you can see in our health system, we have over 12, 13,000 people who wish to get the vaccine. I'm not going to talk about messaging, except that you probably would want to know that there are populations out there, and I think others are going to speak to this, that are very, very mistrustful, both culturally and for other reasons, of vaccination. And we're making a special effort to make sure that these people who might otherwise feel somewhat disenfranchised have equal opportunity for education and the ability to sign up and get the vaccine. So some of you are thinking, well, okay, so that's you in healthcare. What about the rest of us at JHU? You're going to be in phase 6. We don't have enough guidance from the state or the feds as to how people who are not involved in healthcare are going to be vaccinated. So this time we don't know if it's the same as, say, for flu vaccine, and whether the health system will play a role in distributing it to people in all of the campuses that are non-clinical campuses. If you go on our website, inside Johns Hopkins Medicine, there's all sorts of data on what we're doing, why we're doing it, and all the background, including a whole series of FAQs. I won't answer them now, but maybe some of the questions will be along these lines. I want to end with safety. The trials only went out for 2 months. Obviously, at this point, it's 2, 3, 4 months. But people are actually being surveilled all the way for 2 years. So we're going to know more about long-term effects as we go along. Some of you are wondering what's in the vaccine. This is about as pure as you get. You have mRNA. You have a very fancy set of lipids. and salts like potassium and sodium and a little bit of sugar, you say, well, hey, I don't want to put that in my body. But here's America's favorite meal that people are willing to put in their body. And if you walk down the supermarket aisle, people are putting all sorts of nonsense in their body every day that is way more immunogenic than anything that this mRNA vaccine might pose as a risk. People have been worried about mRNA. Does it combine with my genetics? Will it harm my DNA? Will it cause autoimmune phenomena? No, doesn't seem to. The mRNA stays local. Autoimmune response is thus avoided. It's very unstable. It dissipates quickly, so it's metabolized quickly, and it doesn't go into the nucleus of the cell, so it can't mess with your DNA. I mentioned this issue about Bell's palsy. Pfizer and Moderna both had small rates of it, and it's sort of normal in the population. I'm trying to dig a little further, and I found that at least one of these was actually a stroke, which is completely different than Bell's palsy. But I ran my own little chi-square on the data, and it's right at the edge of whether you might want to consider this a significant difference. So the issue of Bell's palsy is going to be monitored as part of vaccine trials. People worry about getting Guillain-Barré from vaccine. Guillain-Barré is what's called an ascending paralysis syndrome. You start losing the ability to move your lower limbs, and it moves up all the way where you can't breathe, because even your chest muscles don't move anymore, so you might have to be intubated. It was a big issue late in the Ford administration when there was a swine flu outbreak at one of the army bases, and there was a fair amount of Guillain-Barré at that time. Since then, vaccines have not only not been associated with Guillain-Barré, but there's some suggestion it may even be somewhat protective. All right, 2 slides and we're done. So the big question is, what is the risk benefit of getting this vaccine versus not getting this vaccine? So these are infection rate mortality numbers on the left and case fatality rates on the right. The infection is lower because a lot of people don't know they're infected. They're fairly mild. And so we looked at the numbers here of the likelihood of death, and including those 15 to 19, kind of the earlier age group that might be going to university. And we did some calculations here. We're gonna have to dig a little deeper in this. These are very simple calculations for the record. So for the population to reach herd immunity, you need about 75% of the population immunized either through natural infection or vaccine. If only 50%, for simplicity's sake, of the population is willing and does get vaccinated, or even a little higher, but it's not perfect, so about 50% are immunized, that leaves about 50% who is otherwise susceptible. So half of those ultimately will become infected until this herd immunity magic number is reached. So we did some calculations for the different age groups. Assuming that you choose not to be vaccinated and you remain susceptible, your likelihood of dying from COVID, depending on your age group, obviously in this upper age group, it's like 1 in 200, but even in the 15 to 19-year-olds, it's not exactly trivial, it's 1 in 40,000. The likelihood of having permanent disability is, in these upper age groups, 1 in 20 or so. In this younger age group, 1 in 200, so not trivial. How does that relate to adverse events and death from vaccine? Except for maybe in this group, it's not even in the ballpark. And even if I'm off by 10 or 100 in some of these, it's not a close call. So could something happen if you get vaccinated? Sure. But the risk, especially once you get out of the very young age groups, just is simply not worth it. And so I will stop there. And again, thank you for allowing me to present this.
Thank you very much, Dr. Killen. And you presented some data on or some of the plans for prioritization And I wanted actually to turn to Dr. Cass. We know many considerations go into these decisions about how individuals are prioritized. And I think it would be useful if, from your perspective, both working on the committee as well as from bioethics, what are the principles that help guide prioritizations like this?
Yeah, thanks so much for the question. So in the largest sense, there are goals of benefit. Where do we see the biggest benefit from the vaccine, and how do we do it fairly or equitably? But even within this category of benefit, that can be defined in lots of different ways. And we start to see some slight differences in the allocation schemes that different expert committees and different states have put forward. So one way that the vaccine can provide benefit is preventing death. We've seen so much death from COVID. Part of what Gabe showed in some of his slides was death that we've seen or the risk of death. And so this putting priority on nursing home residents is directly a strategy to try to prevent death. That is a group that has experienced about as high death as any subpopulation within the United States. There's a second kind of goal where we might call it a public health kind of goal, where we're trying to prevent spread. We know that this is infectious, and there are certain people who just have a lot more contact with other people by virtue perhaps of their job or their profession. And they're both at higher risk because of that extra contact of getting COVID themselves, but they are then in turn at greater risk of spreading it. And if we can vaccinate some of the people with a lot of contact, the people moving around more, then we can achieve benefit that way. And then the third way that people in these discussions have been defining benefit, which Gabe also touched on, is essentiality. There are certain people on whom all of us rely for continuing to maintain functions that we all need. So healthcare workers are an example, grocery workers are an example, teachers are a group that we're really eager to have come back. So in the Maryland state allocation, we've seen a particular privileging of healthcare workers and of nursing home residents, as I have said. I want to say a little bit more about some of the role that healthcare workers play, because while most allocation schemes privilege healthcare workers, not everyone says that they are, there are other groups, as I've said, that also have a lot of interaction. And for example, grocery workers don't have as much PPE or protective equipment as healthcare workers do. I think that one reason why healthcare workers have been, there are multiple reasons why healthcare workers are high on a lot of these prioritization lists. One of them, again, is that they are essential, and we all need to be able to go to healthcare workers, not only if we get COVID, but if we're having a baby or we get appendicitis or we break our legs. Another is a fancy word we use in ethics called reciprocity, which means these are people who've been showing up for 9 months when it's really hard and there are high risks and there's really high stress. And there's a way of saying, look, we want to take care of you. We care about you. And that is a strategy. They have high contact, as I've already said. And there's another piece that I honestly haven't heard people talk about as much, but I think is going to be really important in COVID, which is that they also become the messengers and often the point of first contact for everybody else, including in phase 6, who are going to be vaccinated. And if the doctor or nurse who's vaccinating you can say, let me tell you what it was like. All my colleagues have been vaccinated. Yeah, I felt crappy for a day or two, and then I was fine, and it's such a relief. That's really important. So I just want to say a word about the other important ethics priority, which is fairness or equity. I know that Dr. Cooper is going to talk a lot about this. It is really essential that we think about all subgroups in society when we're doing prioritization. When we talk about healthcare personnel, as Gabe already mentioned, that's sort of naturally built into the infrastructure. Point of contact healthcare people include the doctors, include the respiratory therapists, include the food service people. There are people from all different incomes and races, and that is built in. So we sort of get the fair allocation in the way a lot of these are built out. What we don't necessarily get to, and again, this is an area where Lisa has a lot of expertise, is equivalent uptake. It's one thing to make a vaccine equally available to people from a lot of different groups, and it's a whole other ballgame to make sure that people from different groups feel equally comfortable because they've had very different life experiences with the healthcare system. So that's another task before us.
Great. Thank you very much. And having talked to some of our colleagues working on the front lines, we know that they are under tremendous amount of pressure, and our hearts go out for all of the tremendous heroic efforts that they are doing. I want to turn next to Dr. Cooper. As Dr. Kellen said, we know the effectiveness of the vaccine in reducing COVID disruptions will depend on the uptake. And yet we've seen with studies, and there may be some listening to this town hall, that the number of people who are skeptical about taking a COVID vaccine is not insubstantial. And this is particularly true in Black and Latinx communities. So Dr. Cooper, I'd love to hear about your own perspective on this, and sharing your thoughts on what the Johns Hopkins community can do to help come together to help overcome some of this skepticism.
Sure. Sure, Steve. Thank you. I'd be happy to comment on that. So, we know that actually mistrust in science is at an all-time high right now across the board, but that issues of trust in science and health care are much more serious in communities of color because of, structural racism, because of experiences of discrimination, and, just honestly because of historical oppression. And so, I think one of the things that we're hearing a lot about and seeing in the surveys is that there's a much lower rate of vaccine acceptance in communities of color, particularly among African Americans. They are recalling things from a historical perspective based on, experiences with minority communities, with scientists through the Tuskegee syphilis experiment, and all of those kinds of things. So I think one of the challenges we have right now is actually engaging with those communities and sort of, making sure that we as scientists and health professionals and public health professionals show ourselves to be trustworthy. So we really have to get out front and go out there, engage with communities, build on existing relationships when we have them, and make sure we're listening first to people's concerns, not going out there lecturing them and overwhelming people with too much information, but basically first listening to what the concerns are, building on existing relationships, working with trusted partners, people that we know that are trusted in the community, might be faith leaders, they might be leaders of small businesses, they might be actually just community-based physicians or other health professionals. And then in different age groups, for example, there might be other groups of people that might be influential, people like local celebrities or athletes or entertainers. We really need to work with those folks to see if they can get accurate information from us and whether they would be willing to be messengers on our behalf. I think some of the things we need to communicate is relate to the fact that there have been a lot of changes in science over time to protect people from harm in science, and also to reiterate for people that there were diverse groups of people included in the trials, in the vaccine trials. So we know both the Pfizer and Moderna trial had a significant, several thousands and thousands of people of African descent, African Americans, also Latino, a smaller number of Asians and American Indians, but still significant numbers included in those studies, and that the effectiveness of the vaccine and the side effects from the vaccine were no different in those groups than they were in white. So I think we really need to get that message out. And we also need to, not only talk about those things, but also acknowledge the harms that have happened in the past and the mistakes that have happened in the past. So not try to brush those off, and to be very transparent, like as Gabe was, today, about some of the things we don't know. Don't act as if we know everything. Say what we know right now and what we don't know, and make sure people know that communication is going to be ongoing. So be very transparent. So these are some of the things that that I think will help. I know that there are lots of efforts going on a national level. The NIH has invested a lot in this, so has the CDC. We are going to have to try different kinds of messaging for different kinds of people. People may not separate in terms of their beliefs about the vaccine based on only race or ethnicity. It might be about just their general health beliefs or their religious beliefs or their political views. So we have to keep in mind that even though people might belong to a certain demographic group, we don't have to assume that they're going to feel a certain way. We really need to try to reach people where they are as individuals, at the same time taking into consideration the demographic group they belong to and what they've experienced historically.
That's great. Thank you very much, Dr. Cooper. Next, I want to turn to Dr. Links. And the next several days, we'll be releasing our updated phase 2 return to campus plan. And perhaps, John, you could talk about how the vaccine rollout intersects with not only our spring planning, but our planning after that. Several questions have come in about people who may be interested in receiving the vaccine that aren't part of the healthcare system, for example.
Great. So let me address a couple of questions. So first, will the vaccine influence our spring semester operating posture? In a word, no. If you think about the availability of doses and the prioritization scheme, along with the need for 2 doses per person spaced 3 or 4 weeks apart, by the time we get to Gabe's 75% herd immunity, spring semester will be over. Having said that, we do think that COVID vaccination will play a role in helping our fall 2021 operating posture. Will the vaccine be required? Not now and not for the foreseeable future. So we need to get to the point where it's widely available, where we have experience with its safety and efficacy in many millions of people, and where its licensing is more permanent than an emergency use authorization. At that point, we'll reconsider. And then the question everyone who's not a frontline healthcare worker is asking, when will I get vaccinated? So Gabe talked about a series of priority levels and said that, the rest of us are in priority level 6. And in fact, that is certainly where many of our students, faculty and staff fall. Those with comorbidities may be at a higher priority level and could get vaccinated sooner, but sooner means sometime in the spring at best, not earlier.
Great. Thank you, Dr. Links. Looking at the different, questions that have come in, Dr. Kellen, couple of questions to follow up on your presentation. One is just a clarification. You'd mentioned when people are signing up, you talked about randomization, and I think it's probably important to just clarify what you meant by that. You're by no means at this point randomizing people to receive the vaccine or a placebo, correct?
Correct. Yeah. We originally used the word lottery, and that had certain connotations. So it's like random assignment, but even that gives an idea that some people get the vaccine, some don't. What we're really doing is, we have like 12, 13,000 people who want to get it, 1,000 people who can get it in this first round. So we're doing under the hood a randomization scheme as to who among those 12, 13,000 should get the first 1,000. So that's what we meant.
And just following up, there was a question about, some of the side effects that you pointed to, in particular about Bell's palsy. Is that typically something that's permanent or temporary manifestation?
Yeah, the vast majority do recover unfortunately. It may take weeks and even months, could take up to half a year for some people, but most people recover in a few weeks. But in a few, but fairly few, unfortunate cases, it can be permanent.
Uh, And another question just about, the idea of assurance. Given that this vaccine is complicated to ship, how can people be sure that, has been shipped appropriately and isn't compromised?
Great question. So in one of the slides, I showed that box that it comes in. So Pfizer ships it on dry ice with a sensor in it that feeds back constantly to Pfizer's headquarters to see if the -70 degrees had ever been broken. After that, it's our responsibility. We have a -70 fridge, it goes even lower, to store it properly and handle it properly. It can't be out of -70 for more than 3 minutes, after which there's no sense putting it back. It starts to degrade and you have to then use it within 5 days. Even then, if refrigerated at freezer temperatures. And once you reconstitute it, then you've got about an hour to use up what's in the vials.
Great, thank you. Dr. Cooper, I wanted to go to you, just some questions about, issues of interacting with people who, as you noted, may have different perspectives of, whether this is a mandate versus, something that's not mandated. Could you just talk a little bit about, your own perspectives of, recognizing that we have a long history, as you said, of different types of medical interventions coming out, and many choices that both healthcare professionals as well as people themselves have to make with all of these, advances.
Right. No, I think it's a really important time for us to consider the different viewpoints that people in our society have. This is it's been a very emotionally charged time, and unfortunately, COVID-19 and its treatment and prevention has become very much politicized. And so I think it's really incumbent upon us as health professionals, even as just private citizens, people who are well informed or connected with science and medicine in some way, that we don't approach others in a judgmental manner about this. First of all, this is the vaccines have been approved for emergency use right now and have not been approved widely yet. We expect they will be, but I think it's really important for us to remember that we don't need to feel that we have to force everyone to take this vaccine, and that in fact that may actually backfire. I think the approach that I think works best is for everyone to get the information, the most accurate information that's available from a trusted source, and just encourage people to do that, have them to talk to their doctor or to a family member or somebody they really trust, and to have all the accurate information. And then it's going to be up to them to make their own decision. And the less judgmental we are about this, and the more we sort of just allow people to examine this and watch other people's behavior, I think we're going to be more likely to see a greater uptake of it than if we become judgmental about it and try to become confrontational about it. So I think that's going to be a huge issue for communities of color, but for other groups, obviously for lots of people who are feeling disenfranchised right now and skeptical of authority.
Some people, and there was at least one question, that talked about the fact that we have a influenza vaccination, requirement. Both the health system has had that for many years, and now as part of our COVID barriers that we are putting up to protect the community, we've instituted that. Maybe John, I could direct this to you. In terms of, do we anticipate something similar here for COVID vaccines? Is that going to be a requirement to come back to school in the fall?
So there really is right now a very big difference between the flu vaccine and the COVID vaccine. The flu vaccine is an incredibly well-established vaccine with a long history. COVID, as Gabe and Lisa have been highlighting, is a newer vaccine whose use is only approved under an emergency use authorization. So certainly no time soon would we even consider mandating the COVID vaccine. It's really too soon to say what our thinking would be like for the fall. But I do want to remind everyone that even with the flu vaccine, there is a very well-established exemption process for medical or religious reasons. So even with the flu vaccine, it isn't automatically forced on everyone.
Great, thank you. Another question that I think is important is has to do with our current protections, right? And whether they would need to continue even with a vaccine coming out. Be interested in anyone's thoughts on how long masking will be part of our lives.
I can start with that. At this time, we do not know if you can become infected, even if you're vaccinated and immune. There's some evidence, particularly in the Moderna trial, that you will not harbor the virus as significantly as those that were in the placebo group. So given that at least 5 to 10%, and in real life it may be higher, the vaccine doesn't take anyway, plus you may yet be a carrier. Until we have those kind of, and reach herd immunity, until we have those answers, it'll be very strongly advocated that the standard distancing and masking continue to occur.
Yeah, it's on the university side, we're not even remotely contemplating letting up on masking, distancing, hygiene, our room ventilation efforts through the spring and summer. The model that we like to think about is think of a bunch of slices of Swiss cheese, and the first Swiss cheese slice is about masking, and the second one is about distancing, and the third is about hygiene, and the fourth is room ventilation, and the fifth is frequent testing, and the sixth is the vaccine. And each Swiss cheese slice has some holes in it, and it's only when you line them all up that the next slices block the holes in the previous slices, and together nothing's getting through. So we're thinking about additive, not substitute. The vaccine for now is not substituting for other control measures, it's adding to them.
Great, thank you. There was a comment, Dr. Kellen, that you made about the AstraZeneca vaccine. Could you just expand upon that a little bit?
Sure, a bit of a fiasco in terms of AstraZeneca handled what was going on. They had a couple of cases early with something called transverse myelitis, not a good thing to have, probably not related to the vaccine, but they had already known this and had a meeting with the FDA and didn't reveal it. And then it came out 2 days later. Then they screwed up their trial when one of the contractors in one of the countries misunderstood what the dose was supposed to be and gave half the dose and then gave the full dose for the second dose. And bizarrely, those people did better than what the trial was supposed to do. So the people that got the real dose were only 62% decreased, whereas the people who got the higher dose, that sort of weird mix, will give you half the dose first and the real dose second, they were 90%. So there's a little bit of mistrust. They mixed and matched their data from the two countries and so forth. So just a lot of mistrust. And they're going to have to work really hard to regain the trust of the FDA.
Thank you. There was also, we had a little bit of discussion. I think this issue of trust is so important. Dr. Cooper, before we started, you mentioned that you had actually participated for a short period of time on one of the data safety and monitoring boards. Could you maybe just talk a little bit about your experience on those? I realize not everyone in the community may have an understanding of what that role is.
Sure, I'm happy to do that. Yeah, the board involves scientists from several different disciplines, from all over the world, actually. It involves people who are experts in vaccines, clearly, people who are experts in biostatistics, that look at the actual data, people that are epidemiologists who look at study design, people who are experts in children, people with certain conditions, chronic comorbid conditions, and also people who are experienced in working with diverse communities, such as myself, and I'm also a primary care physician. And so we have these diverse perspectives that are included in our discussions. We review the data that come from the study very, very regularly, especially for a trials like these, where we're really like enrolling people very rapidly. We were looking at data on a weekly basis, getting reports on any events that occurred as they occurred in real time, and looking at it and being very careful to note whether there were any differences between the groups. There's a lot of deliberation that goes on around this. It's very, it's completely sealed off from the people who are doing the science and the people who are funding it, so that they don't have influence over those decisions. They look through carefully to make sure that there aren't conflicts of interest for the scientists who are involved. They don't have any kind of financial or other kind of reason for wanting the study results to go one way or another. So it's a very, very controlled, careful process, with lots of people from all kinds of backgrounds giving very, very careful and serious consideration to all of it before actually saying that they feel that the results are safe to move to the next phase. We also look at different populations of people. So for example, people are wondering now why the vaccine isn't available to children. It's because we start out with adults, and we often start out with the healthiest people. And if they do okay, and we can feel confident about that, then we move to people who are greater at risk for things going wrong with them. So a lot of protections in place. And I think people should feel very comfortable that, everything possible is being done to protect them.
Great. Thank you. I actually want to follow up with that, having served on a many DSMB myself, there's always, a statistician, right? And there's always an ethicist, on all of the boards that I've been on. And so actually, Nancy, maybe you could talk a little bit about, your own perspective and contributions that ethics, is a primary consideration for these boards as well.
Yeah, thanks, Stephen. And I will say that Lisa and I actually served on the same DSMB for the NIH Ebola trials, and talked about so many of these same issues in a different context. So you're absolutely right. I mean, I think that, wearing that lens of ethics, there are a couple of reasons why that is one of many, many, many types of expertise that's often at the table. And a lot of it is, so some of it is this standard thing that everybody's doing, of weighing the risks and benefits and making sure it's fair, which honestly, I think everybody around the table who's thoughtful does. There is also this lens on what is the experience of the people, and what is it that the people are thinking. One of the issues that came up at the hearings today in the FDA Moderna trials, which came up last week at the Pfizer trials, was what happens to the placebo group in the trials that are still ongoing. And that's the kind of thing that everybody's thinking about, but certainly the ethics people as well. I think that one of the reasons why the DSMB is so important is, as Lisa said, to be able to be another mechanism that ensures that this whole research process is trustworthy, right? People could get suspicious that the company who makes the vaccine, who has money at stake, might have a conflict of interest. And there are people now who don't trust the government, particularly in the last year. And so this is a group of people who to some degree have nothing to gain or lose. And it is entirely their job at a few places along the way to look at the data, to see what's going on, to say, should the trial be stopped early because the results are so good or so bad, or should it keep going? And having that extra look, I think, is really important. If I can, I just want to say one other thing about trust. And we all are living in the same country. We all know that there are a lot of people in the country who have expressed concern about whether there are people who can't wait for their turn to get the vaccine, and there are the people who are hesitant, and they both need to be taken really seriously. I have a view, and maybe it's because I have like my rose-colored glasses, but I do think that this supply constraint to some degree carries a silver lining with it. Most of us don't have the chance to get the vaccine for at least a month and probably a few months. And by the time it's our turn, tens of millions of Americans will have been vaccinated, and we will have watched what happens. And assuming it's the same as what happened to the tens of thousands of people in the Pfizer and Moderna trials, chances are they're going to do just fine. They're going to, again, feel not great for a day or two, and then they're going to be fine. And by the time it gets to be the turn of everybody else, my hypothesis, we'll see whether it's true or not, is that some of the people who now feel a bit anxious are going to be right there in line for their vaccine.
Certainly hope so. I want to just ask one more question. Given that we will have more than one vaccine out there, a natural question is going to be, should I wait for the Moderna vaccine versus, what we know about the Pfizer vaccine? Let me ask, Dr. Kaelin, based on the data that you showed, as well as the emerging data from the other studies, is there any reason to wait? And is there any reason there will be differences in distribution?
Don't know a lot about how the government plans to distribute. I assume it's going to be very similar to Pfizer, with one exception. Moderna is US produced, and along with the NIH, it was funded by the US government. But the other question, should you wait? I guess I would say wait for what? 95% efficacy, take it while you can. Most people who have tuned in here are going to be forced to wait because, and you may or may not have a choice, quite frankly. The Moderna is easier to handle in the healthcare setting. That may go to more rural and smaller hospitals, a lot less complicated in terms of how it's handled, than the more sophisticated medical systems may preferentially get the Pfizer. From my own perspective, I'll take what I can get. I'm happy with either.
And I presume there was a question for a previous town hall. Will you take the vaccine? And I can certainly pledge, yes, I will take the vaccine. I think all of us are pledging that we will take the vaccine. So it's right around 5 o'clock. Let me close first by thanking our panelists, as well as all of you who attended the town hall. While we weren't able to answer every question, hope this session has been able to provide further insights. As you heard, there are a number of unanswered questions still remaining regarding the plans for vaccination outside the healthcare system. We will keep you informed as plans come together and schedule additional information sessions when appropriate. I also want to mention the Coronavirus Resource Center website, which I'll note, Time Magazine noted as one of the best inventions of 2020. In addition to serving as a go-to data source, there's a wealth of information on vaccines on the website, including frequently asked questions, a series of brief reports on vaccine development, as well as videos from an October symposium between Johns Hopkins University and the University of Washington. This session was recorded, and an archive will be provided on the website as with our other town halls. Until next time, please help be our ambassadors to only spread one thing for us: the right facts about COVID vaccines. And please keep adhering to good public health measures to reduce the spread of COVID itself, including washing your hands, avoiding close contact, and maintaining physical distance in public settings. Keep wearing a face mask when in public, and please continue to take care of yourself, your mental health. Please take advantage of university resources to help you during our continued disrupted environment. Keep safe, and we look forward to talking with you soon. Thank you.